What's good, y'all? Welcome to another Anything by Mansa Cannon. I'm Mansa, and today I got my guy, Dr. Dwayne Whitfield. Please put that doctor on the front of it, and he is an MD, so he's going to actually know how to take care of you. This guy is going to be able to give us some really inside information, some real good information related to how he became a doctor. I was actually around, I guess I technically have known you for almost 5 years now, really, when I think about it, because you were in college with Courtney. And that was right before you got your doctorate. So yeah. I've seen this guy pre-doctor and now I see him post-doctor. And I got to tell you, I haven't seen a major change. This guy seems like he's always been a consummate professional, even when he was having fun. And I'm excited today to get to what we're going to talk about. So without further ado, my guy, Doc, what's popping, man?
Nothing much, man. Appreciate you for having me on. Nothing much.
Okay. Well, because I have you on, I have to ask the most important question, which is, do you enjoy your job?
Yeah, no, good question. And the answer is just yes, simply yes, So just to kind of expand on that a little bit, I am a family physician, right? So, I have the honor of and privilege of, treating patients from what we call the womb to the tomb. So womb being we're taking care of newborns, we can deliver newborns all the way to the tomb. We're there are patients who are 99 and 100 years old on my list. So to just be able to have that opportunity to have comprehensive care for all patients of all ages, genders, sexes, any acute or chronic condition going on, it's an absolute joy. And and honestly, it's a good question because not all doctors can say that. So short answer is yes, but I'll once we go more into it, I kind of expand on a couple more things on what I enjoy about it.
Yeah, well, I have to ask that question off the back to make sure that I'm not presenting somebody who hates their jobs and Mondays.
Yeah.
I'm not sure if you really deal with strictly Mondays. We're gonna get to your actual calendar and what that looks like as well.
Yeah.
What was your first job that you ever wanted? What was the first career profession that you thought of as a child? What's that first one? It could be ridiculous. I've had somebody said a cool one like James Bond. I wanted to be Michael Jordan. Neither one of those made sense, but he wanted to be a secret agent, which did. I wanted to actually grow up to be 6'6" and Michael Jordan, which didn't. So
right.
What about you?
I'll say this, growing up in high school, not that I was always the class clown. I didn't take it that far, but I was always trying to make folks laugh, always trying to make people laugh, folks in my friends group, the teachers, anything like that. So part of me always wanted to be like a comedian or an actor. I was going, in the back of my head, I knew I wanted to be a physician, but that was that kind of second thing, that I wanted to do. But I was like, okay, it's going to take a lot to try to get to Hollywood, right? So am I going to be able to do that route? It's still in my back pocket. I'm not giving it up. My wife is just like, oh, this dude right here, this boy is crazy. But that'll be my alternative dream job right there, being a comedian / actor.
Well, I do want to remind you that, and I don't know if you already are thinking about it. We have Dr. Ken out there. I mean, he doesn't get called doctor all the time, but I mean,
right.
Dr. Ken is out there, and he starred in the freaking Hangover and everything else. Masked Singer is my show. Watch every season. So you got the option.
It's possible. Yeah. No, because he was an internal medicine doctor. Yeah, he was in clinic. He finished all his training, actual physician. And I'm sure he made all his patients and everything laugh. And he just said, look, let me make a little detour, went into Hollywood. Like you said, got into one of the, craziest, best movies ever and got to that series. So yeah, it's in my back pocket. Don't worry about that.
Well, I'm not trying to steal you away from what you're currently doing, so I don't put too much out there on that. But I look forward to seeing you in the movie, and I assure you that I could at any point change up my energy, change up my face, and I can be very serious if you need me to be. So if you need another person, a co-star to help you, please.
I got you. I got you.
All right. So where was the switch though? When did you actually go, or better yet, did you ever take the acting part seriously? Was there a switch to you becoming this, and what were the other jobs, I guess I should ask, prior to you deciding to become an actual physician?
Yeah, no, I didn't. No other job, I really took seriously. I mean, honestly, the only actual job I had besides being a physician was I worked at, Burger King, throughout high school. Right. But other than that, it was pretty much, the journey to medicine, ever since graduating high school. My father, I'm the first person in medicine in my family, but my father always stressed the importance of education, finding a solid job with prestige, with financial security, right? So he never just said, hey, do this one thing. He was just always kind of speaking in that general sense when it comes to education, and then, again, finding a profession. And then, college, it may have just started from like a TV show, some Grey's Anatomy or House or something that kind of first got the wheels turning. All right. And then, for college, I was a pre-med biology major. And then, I liked my classes. All right. I liked some of the Black professionals that were around me, and we were kind of pre-med and going on the journey together. And then really the additional turning point was my own interactions with my own family physician. So for me,
okay,
yeah, earlier on, in high school and those early college days, I had a lot of anxiety, social anxiety in particular, so, and I didn't think it was treatable. I was just like, this is just something I got to live with. Every time if you rewind 10 years ago, I wouldn't be able to do this. I'd be sweating. This thing be soaked right now. I'd be stuttering, mouth dry. Wouldn't be able to do
10 years ago. Okay, you said 10 years ago. I'm like, I bet you had all the personality. Like,
but seriously, I wouldn't be able to do this. And then there came a time I was just like, okay, let me speak with my family physician. Because even at that time, I didn't think he was going to be able to treat it. But I spoke with him about it, and he was like, look, this is a very common thing for folks your age. I deal with this all the time. He talked me down, made me feel comfortable, put me on a therapeutic regimen. I was on it for a couple of years, and my anxiety just got so much better. My grades got better. I was able to, network and speak with people and, lead more organizations. I'm talking about like a complete 180 in who I was, right? Really kind of tapping into my potential. So then I kind of reflected on that, and I said, okay, if a family physician can do this for one patient, just one person, I'm like, what else can these guys do? It's just one person's life that they kind of quite literally changed. So what else can they do? So that's when I took pre-med more seriously. And then once I graduated from college, I had to do a 1-year post-bac program. We could talk about that a little bit later. And then I did my 4 years of med school, but I was really focused on family medicine in medical school. So I shadowed a lot of family physicians, read up a lot about it. I was president of the family medicine interest group at my medical school. And then after that, I said, look, I'm going to apply for family medicine. And, to go back to answer your first question, yes, this is why I love the job, because I had such a deep experience, internalized experience from it, when I was a youngin' at the time, that it was just something I knew I wanted to do, growing up. And, I feel that same, joy with a lot of the patients. Look, I have a lot of patients who have the same story that I have, just little teenage or young 20-year-olds, anxious, just can't be around people, for whatever the case may be. And I tell them the same thing. Look, I dealt with this with my family doc. We can help deal with this too. So that's where I'm at right now.
Since you said it, I don't want to just leave those people hanging that potentially are struggling with the things that you struggle with, and that has a kid that is. So just briefly, can you give I know you can't just go over all the years of exactly what happened in treatment, but can you give like a general idea of what the doctor did or what the treatment was that helped you improve your anxiety and your social skills?
Yeah. So there's tons of different types of anxiety. You have some folks that can have generalized anxiety, which is just whatever kind of comes in their head that they think about, it makes them anxious. It could be about bills. It could be about something in a year down the future. It could be about, their parents' health condition. It could be about their work-life balance. It could be about anything that kind of makes them anxious. Me in particular, and a lot of patients a lot of folks in their teenage or young 20s age deal with specifically social anxiety, which is, when you get put into particular social situations, that's when you start to get those kind of non-specific anxiety symptoms. The heart starts racing, you start sweating, and you start to get this kind of surreal feeling where you can't, you kind of disoriented, you can't concentrate. Huh?
That was you.
That was me, right? That was me. And there's a lot of different treatments for it. So you have the medication route, and then you have like the kind of behavioral therapy route. You know, where there's some exercises, like mental exercises you could do at home. There are therapists you can see. I never went that route because I was more busy, but it's still a very trustworthy, study proven route that's effective. I went more the medication route, right? So there are these, anti-anxiety pills. Nothing it's not a controlled substance, even though I know some physicians do that, but I tend to recommend against that for long-term basis. But there was these pills you just take once a day. And essentially what it does is it kind of helps stabilize and increase this particular neurotransmitter in the brain called serotonin. Serotonin is kind of like our mood hormone, which kind of helps control anxiety, depression, folks with PTSD, obsessive compulsive disorder, all these different conditions all kind of focus on that one neurotransmitter. So just over time, be on this medication for years, I would still be in the same social situations, right? I would still have to do interviews and lead organizations and talk to new people. But my perception of that particular situation was no longer an anxiety filled thing. Right. So that's the biggest, purpose and mechanism of these medications. So, yeah, over time, I just, my anxiety just got so much better. And then I kind of end up getting off the medication. And that's where I'm at now. So, when I see my patients, I'm a huge advocate for, treating some of those mental health conditions, anxiety, depression, post-traumatic stress disorder, all these things, because they are treatable. A lot of people don't know that. So it's a big deal.
And for clarity, you did receive like training and practice with improving your actual social skills, it sounds like, so you wouldn't have to use the medications the whole time.
Yeah, I didn't do any formal, kind of behavioral therapy, but just the being in this medical field, you're going to be I put myself so much in those situations that it's kind of like sink or swim, if you will. So, for example, when you're in medical school, you're going to be doing a lot of presentations in front of large groups of people. Whether that's presenting a certain PowerPoint on a medical condition that you studied, or when you're making rounds around the hospital on sick patients, and then you have to present the patient's information to your group of colleagues. You're just, and then pretty much on a daily basis, you're doing this multiple times. So, with the help of the medication, and then being in these social situations, just kind of being exposed to it over and over, you kind of naturally become more used to those situations. So again, some people do medication and formal behavioral therapy. I did a medication and then kind of got put into these situations, which was kind of like my behavioral therapy.
And that counts. Yeah, it was practice. And the reason I asked that was, and we'll definitely get to some other things, but I want to say that's really important for people to hear, because coming from a background, my first 5 years was working in a mental health space. I was working as a case manager. I was in charge of a day treatment program. I had a lot of kids that were getting, I worked with substance abusers, and even with them, I was working with a lot of kids that were being prescribed different medications for their issues. And for me, what was frustrating was, unfortunately, a lot of them were not getting that treatment that was going to help wean them off. It was only giving them the stuff that was going to allow them to be subdued during the time period that the school or their parent wanted them to be subdued, opposed to them learning how to manage their body, manage their interactions with others. I mean, I work with the interactions part, but the actual formal training from the specialist, which I'm not going to sit here and take credit and say I am. I was just good at it. I was not seeing that. And that was what was disappointing. And that's why I really wanted to build on that, so someone out there could actually hear the value of it and frankly see the value of it in action right now. I have to ask, you mentioned your parents. What were their jobs?
Yeah. So my father, he was military. He was Army. He served about, I know I'm getting the exact number wrong, like 22 to above over 20 years of service in the military.
Wow.
He retired from the military, and now he's a middle school instructor at a ROTC. ROTC instructor at a middle school in Texas. And my mom, she had, for the most part, she's just been a stay-at-home mom. She had a couple jobs kind of, throughout our childhood, but most of the time, stayed at home, taking care of us, until we, kind of got older and left. But yeah, that's where that's what my parents are doing right now.
Yeah. I'm just curious. I have family that was in the military. I've seen people that were in the military. You can get an array of energy and people, but at the same time, I'm curious to know if the discipline that you had, not only stick with that, but the discipline to make it through all 9 years. And we're going to talk about, and then have you break down those years for us, all 9 years of education. Like that takes a lot of discipline, especially with the level of what you were having to go through and what I assume you were going through. Yeah. Did the discipline and witnessing your father play a role in that? I don't know if there was some type of upbringing that was connected to his military training and how he handled himself. Like if you all went on trips, you had the military row, your stuff. I don't know. I'm just saying in general, was there some type of ingrained discipline based off of his background?
Yeah, 100%. I'm always still in amazement of, my father's upbringing and, how he was able to raise us into me and my big brother, speaking, how he was able to raise us into the men we are today. Seriously, he was, born and raised in Cleveland, Ohio.
Hey, like that.
Yeah, right. And, he was one of the very few who left the city, and then he joined the military, and then met my mom in South Korea. And then they had, me and my brother. And then since then, outside of just me being observant of how he raised us, it was just him, using his proactiveness as a father to, kind of instill those particular qualities and principles in us. I think, and when it comes to, and the military played a big part in it, because we are pretty disciplined and regimen in the things that are, that are important, prioritizing education, prioritizing kind of cleanliness in the house, professionalism when it calls for, just never really having a quitter attitude, right? Because there are times, and we could talk about it later, there are times throughout my journey, it was a little roller coaster ride, right? But, you always get back on, right? And keep it moving. So, yeah, I think, honestly, my upbringing is the major reason, why I'm a physician today. I think, and I respect my own individuality to say, look, I think, myself, I had a large work ethic and I'm very hardworking. That's the reason I'm a physician. But that still stems from, the moral compass, the values, and that constant, advice and pushing and support from my family. That's all. It all stems from that. So yeah, how my dad was raised, his job, and then how he kind of instilled those particular values into us. It got me to where I'm at today. So yeah, all praise to that.
Okay. Mm-hmm. Well, you mentioned it, so let's go ahead and start taking that journey down the path of what you've already walked.
Yeah.
You said you went into college, but you were also inspired by that physician that impacted you. So you answered one of my questions, which was, did you know what type of doctor you wanted to be? Because it sounds like you met a family physician that was the model of what you wanted to become potentially. So when you went into college at Ohio State, did you, and that's Ohio State for the record, not Oregon State.
The Ohio State.
Ohio State.
Got my class ring. Ohio. Okay.
I'm from UC, and so I say this: the best you getting out of me is Spanish Ohio State. That's I'm not. Yeah, my coach. I think I've said this story before. My coach was on the intercom at our own home meet and told the person in the booth, if you say "the" one more time, he said you can. If you listen to the software while the noise is going in the background, you hear him. You say "the" one more time. Yeah, that nah. Ohio State. But if he wants to acknowledge it, how he wants to acknowledge it, y'all be great.
Right.
Anyways, when you went into there, Because you had that level of focus, do you think that helped you with school, the clarity and knowing how you want to proceed? Were you focused a whole lot more than, say, your peers that were still exploratory or had a degree, were going after a degree, but didn't know what they were going to do? Did you see a difference between yourself and them just going in with that clarity?
That's a good question. I'm going to say, off the top of my head, I'm going to say no, because and some of the pre-med students who are hopefully on this, and going to be listening, what you learn in college, all the science that you need to learn, study, the exams and whatnot, it's pretty different from what you're going to be learning as a medical student and then as a physician. It really is. I'll back up a little bit. Everything we talk about now, as medical professionals, they're all rooted in what we learn in college. That's the truth. General chemistry, physics, organic chemistry, biochemistry, all those things. They're definitely rooted in all that. So I can't take them. That's the truth. But the correlation is not on the same platform. It's not, general chemistry formula that that you learn in college. You got to know all 30, 40 of them. It doesn't just completely translate to what we do now as medical professionals. So me wanting to knowing I wanted to be a family physician, or just my curiosity was piqued in that the most. It didn't change, my kind of passion or kind of academic prowess, if you will, when I was in my college days. I struggled a lot in college. Let me back up to high school. High school, didn't really study. High school wasn't that tough for me. I didn't, I took my AP classes and whatnot, but I wasn't a bookworm. I wasn't just boom, 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 boom. I was still trying to be the cool kid in high school, right? But fortunately, I still had a good GPA, got some good letter of recs, had a good college application. But when I got got accepted to Ohio State University for college, Ohio State is a beast. It ain't just athletic. Academically, them boys don't play, right? Especially if you want to be pre-med. So I remember my first quarter, because when I was at school, they were doing quarter systems, and then they eventually transitioned to semesters. My first quarter, I think, I forgot what science class I had and a couple of intro classes. I ended up, and I was working hard. I thought I was working hard, and I ended up with like a 3.4, 3.5 GPA. And I'm like, because it's not even that best GPA, right? But I'm like, I worked my butt off for a 3.5. I'm like, oh, this is about to be crazy. This is yeah. So, subsequently, I struggled a little bit, because specifically, there were some classes that were that's just super tough. Like for me, like the second or third general chemistry class were tough, and there were some math classes that were getting me. Over time, my grades got better as my anxiety got better, which I talked about previously. Then I started to surround myself by, more like-minded individuals, other pre-meds. Kind of, we were on the same study track, right? We're laughing, crying, being mad together. We're in the same classes, so that definitely helped out as well. And then eventually my grades got better. But yeah, it was. And then when I got into post-bac and then med school, I looked back, I was like, man, med school is not even as tough as college was. Some people think it's weird to say that, right?
It is weird to say that. I'm surprised, but you knew better than I do.
For me, and I'll explain why a little later on. It was my post-bac year was really, boom, changed my ability to kind of absorb, medical information. But yeah, med school was just not as tough as college was. And then, fast forward, residency training was not as tough. You know what I'm saying? But it didn't match up to the stress I had in college, which, I know for a lot of people, it's just completely opposite. But I'm glad that was my trajectory, that it kind of got quote unquote easier as I went further in.
Well, you're making me question
life.
I had a question for you, which was, I'm hearing what you're saying about education. And I remember hearing in college, and actually after college, there's a significant amount of information that the average college student, I think the statistic was college students only really retain 25% of all that they learned during their collegiate years. Now, in grad school, that may be different. But I was just curious because it sounds like your foundation was obviously critical to your success. Therefore, you probably retained a significantly more than what we may have done. So, is that accurate, or do you feel like there were a whole lot of classes you forgot as well? And I don't mean those those little fun extracurricular classes.
Some of the side classes I had, the history and all that, I definitely probably only retained a quarter of that information. The science information, I probably retained more because we had to relearn and review it towards the end of prior to applying for medical school. So, I'll kind of generally speak on the science classes that pre-meds have to take. Like I said, the physics, the OChem, the general chemistry, biochemistry. Some of them have like a lab portion to it. You do that like your first, second, and then maybe a little bit of your third year. But then eventually you're going to apply for medical school. But in order to apply for medical school, you got, like you said, you got to have the grades, your letter of regs, your volunteership, community service, your personal statement. But then you also have to take a test, a standardized test called the MCAT. All right, that's that big old standardized test that you got to take, and you before you can fully submit your application. So for that standardized test, you're pretty much reviewing all those science classes that I talked about. So that's to go back to your question, those science classes, because I'm constantly looking at them over and over, whether it's through the huge textbooks, the review textbooks for the practice test. Or through a class where you have tutors, you're going to obviously be retaining more information because you're just looking at it over and over again, even though you haven't had that class since 2-3 years ago. So yeah, that's the short and long of that.
Okay. Well, what was let's go ahead and go through the entire journey now. Yeah. So you were in college, you were pre-med, biology. Yeah. Bio was your actual degree?
Yeah, so the degree was BS, a bachelor's of science, but my major was I was a major in biology, and then I was I minored in Korean.
Korean what? The language?
Yeah, just Korean. Yeah. So there was tons of actual Korean language classes. I took some Korean art classes, Korean history classes within that minor. But yeah, Korean was just the general minor, and then you kind of go into all those specific classes.
Oh snap! So you probably could actually. Wow, I want to stay here, but you have my mind going down the pipeline. So you can essentially cross over. You're going to be a great asset for the Korean community because they need someone to speak to that may even understand the culture. And sometimes culture also shows up in health. And I'm sure that you experience that from time to time. Yeah. So I can only imagine the value that you bring for potential Korean, I don't know, I don't want to say customers, but patients.
Patients, yeah. Yeah.
But you also could potentially go to Korea, I don't know, and actually work there because you know how to speak the language and you have a somewhat of an understanding of the culture. I think you mentioned your mom was Korean. And so I would assume that she probably put some of that in you as well. So yeah,
I would say I'm probably not as fluent as I need to be for medical conversation. I definitely got a lot of work to do on that, but just general conversations, I feel more comfortable. I would definitely still need like a medical translator to help out, for, a Korean patient who, doesn't speak English. But I know enough to get by right now. But yeah, to answer your question, the whole trajectory, and this is important, talk about from step A to step where I'm at now. So yeah, 4 years of college, and I was a biology major. To all the pre-meds out there or folks who are, looking to go to medical school, you do not have to be a science major to go to medical school. You could be literally any major you want to be. You do English major, history, you can do whatever you want, but you have to complete essentially like a pre-med track, meaning do whatever major you want, but there are some particular science classes like the ones I mentioned, and every university and college is different. You'll do your research on that. But you just have to fulfill and complete those particular science classes. Okay. So 4 years of college. And then You can go one or two routes and multiple routes, honestly. A majority of folks go matriculate straight into medical school after those 4 years of college. So 4 years of college, 4 years of medical school. What I did a 1 year post-baccalaureate program right in between. So, what's that? So
Thank you.
not grad school, it's not med school. It is essentially a 1 year enhancing program for different types of students. I was the student who they saw the potential of being a good medical student / physician, but I needed to work on my grades a little bit, right? And then you also have a post-bac program for folks who are new to medicine, meaning they just never thought about being a doctor and now they want to do it. But they're older, they've been out of college for so long, they were a financial accountant, but now they want to go to med school. So they do 1 year and they just take all those science classes, boom, 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 and then apply. Me, I was the former, where I took all my science classes, I took the MCAT, I applied, but they want to see if I can handle the academic rigor. So some of those classes I didn't do so well in, I'm going to be doing during post-bac. So my post-bac was called Med Path program. It was linked to the Ohio State Medical School. So I did it at Ohio State. And I retook my general chemistry classes because I got some C's. In that. I retook those and I ended up getting A's in it. And then I took some kind of med school level rigorous classes, physiology, anatomy, histology, right? And then I got A's, A minuses in all those. I retook that standardized test that I talked about earlier, the MCAT, which for me, it was a beast in itself. Did much better on that. And then I matriculated into Ohio State that following year. So then it was 4 years of medical school, right? In your last year of medical school, then you apply for the specialty you want to go into. Me, I was family medicine, but
it's at the end of the second 4 years.
Correct. Yeah.
So at 8 years, you're now focusing over.
Right. Yeah. Right. 4 years college. I did my 1 year post-bac, 4 years of med school. And then at the end of that, then you're going to then apply, because right now you're still a med student. You're not a doctor. Mm-hmm. And then you're going to apply for your specialty. So that's when folks say, remember, I wanted to do family medicine. So I'm applying for a family medicine residency training program. You can apply for dermatology, internal medicine, ophthalmology. So there's just it's endless. And then once you get accepted into your residency training, you are now officially a medical doctor. You're a doctor now, but you are in training. So you are supervised for fill in the blank on these amount of years. Family medicine is 3 years long. It can range from 3, 4, 5, 6. Neurosurgery is the longest. It's about 6 or 7 years long. So it ranges 3 to 7 years of training. Once you finish that, boom, you then become there's more standardized tests, but you have the opportunity to then become a board certified fill in the blank physician. So now I am I graduated from my 3 year residency training program.
Now we're at 11 years. That's 11 years I'm counting.
Now we're at 11 years.
Well, technically it's 12 because
12 years because of my post-bac. Yeah. So after 12 years.
But it doesn't have to be 12. It could be 11 if you go straight to college, go straight to med school.
Correct. Yeah. Okay. Correct. So after 12 years, I am now a board certified family physician. And now since July of last year, I've just been working in an outpatient clinic, me and 2 other family physicians. We're working a kind of 4.5 day week schedule, Monday through Friday, and I'm off Friday afternoon, seeing patients from 8 to 5 p.m., 8 to 4:30 p.m., weekends off. I don't really have to hold a pager. I'm not on call doing 24-hour calls or anything like that.
Is that because your family? Is that because your family? You get to schedule them opposed to I don't understand that. I would assume that the TV shows make it seem like you're at home, you get the page, and I gotta go in. And something just happened. It's an emergency.
So it does depend on your specialty. If you are a family physician or any physician for that matter, just seeing patients in clinic, you typically don't have that pager and you're running to the hospital. That's a whole nother situation because, to be able to actually just run in the hospital and see patients, you actually have to have hospital privileges, so like I said, it depends on your specialty. It depends on, what you negotiate within your contract. Yeah. But for me, I work just kind of that 8 to 5, Monday through Friday in clinic. There are times where I need to be available on call. So for example, let's say, it's a Saturday, I'm not in clinic, right? I'm at home, but, a patient is having some sort of side effect to some antibiotic I put them on, and I can't, I'm not in clinic. They call like my outpatient pager line, and then the service calls me, hey, Dr. Whitfield, I have a patient who's trying to get in touch with you, saying they're having a rash because of this. Are you available to speak? And then they'll kind of transfer us over, and then I'll speak with them. All right. You don't have to do that every day, every weekend, or anything like that. You typically share that responsibility with the other physicians that you work with. So that's just me as a family physician. But there are tons of physicians who they work in the hospital and it's Grey's Anatomy style, not that detailed and dramatic, but they're running around the hospital doing particular things. But yeah, that's not what I do for my job.
Okay. Huh.
Yeah.
Well, I don't want to just leave out. You left out a little middle part, which is you getting the job. How did you get that job? Like, was this like from the residency? They just brought you in. What does it look like for a person that just got done finishing their residency and them trying to find a job? Because if I remember correctly, I remember you and your wife wanting to go to where you all are now, or at least you all wanted to travel after you all graduated to a new location.
Yeah.
For that. So please speak a little bit about that, becoming the actual doctor at an actual clinic.
Yeah, me getting this first job after residency is a little different from where, how I'm getting my second job pretty soon here. So my first job, like I said, I was a family medicine resident physician at the time, right? The hospital I was training at, and I stayed there for my current job. So the transition was a little bit easier, right? They knew about me, they trusted me, they knew my work ethic. So it wasn't really hey, you're a new person, I'm going to interview you from step one. It wasn't really like that. But for me, it was a little bit kind of easier getting into the process of getting this clinic job. So, essentially it's just kind of, emailing the, I think the term was like, I mean, the CFO or the physician recruiter, just kind of easier play, the person who's in charge of hiring physicians, just emailing them, letting them know my interest in staying within, my hospital's clinic. Then we set up the date to actually have a sit down and kind of discuss the generals of a contract with them. And then these contracts are typically thick, right? So it took me a week or so to just go home, look over myself, to kind of go through it and kind of learn some of the terminology. So I'm doing a lot of research on it. I felt comfortable with it, right? You got to feel comfortable with your contract. And then when I went back is when I kind of actually, essentially signed the dotted line, if you will. And then I started, work right after that, because my wife and I are going to be moving to Texas. We're in Louisiana right now. We're going to be moving to Texas for work. Now I got to look for another job, right? So that process, because I'm a new physician going to a new area, the process of getting a job is a lot, is a lot more. So there are a lot of online websites, right, where you can, it's kind of like just like LinkedIn, if you will, where you're going to be putting yourself out there, putting your resume, your CV, your peer references, your kind of all your accomplishments and accolades throughout. There's multiple more things you put on there, but you're essentially showing your interest on these websites. Hopefully you get a hit back, you get some correspondence back. And then hopefully at that point you now have an interview. So I did get an interview for my new spot in Dallas, Texas, where I'll be working. And it was it's a long interview process, credentialing process, checking your background.
Okay, yeah, there we go.
Yeah, background, criminal, make sure you ain't been running crazy for the past 10 years, all that stuff.
Making sure you haven't had a whole lot of issues with actual patients and things like that.
Yeah. Oh, they look at all that. So yeah, if you've ever had like a patient complaint or you're part of a lawsuit, you got to put all that stuff on there. Yeah, they take that very seriously. So yeah, you go through the whole process, and then if you meet everything and you get approved through the credentialing process, then you go into what I talked about, the generals of the contract, look it over, take some time. If you want to negotiate whatever the case may be, you do that, and then after that, you sign the dotted line and get started at your new job. So yeah, it's just like any other. Really, it's just like any other job. Where you show your interest. If they're interested in you, they hit you back up. Interview process. Make sure you squared away. Credentialing, background checks, and then sign the dotted line and get started.
For clarity, the website that you were using, it wasn't LinkedIn. It's a special website for doctors.
Yeah, I'm forgetting the specific name of it, but there are physician job search engines. Yeah, they are. Yeah, they're specific ones where I'm not sure how they get the information. It's probably the physician recruiters who update it. Mm-hmm. But yeah, we can put our information on a website for job availability in any state, any city. And they kind of spits out the results, and you'll see what spots are available. So you can do it through that way. Some people get jobs through word of mouth. Hey, I work at this clinic, and somebody just resigned, or someone's on leave, and I don't think they're coming back. They really need a physician to fill the spot. I can get you hooked up with my physician recruiter, and y'all can touch base. So there's tons of ways to kind of go about it. But most of it is typically through these online search engines and kind of seeing through the availability through that way.
How difficult is it for you to just become a doctor in another city? Like, I know you just told the process, but is it actually that complicated? Because I mean, hospitals seem like they're jam-packed with humans and always need help. And I'm assuming, clinics seem like they're a little bit more calmer than, say, an ER in a major hospital in, say, Cincinnati or Cleveland or whatnot, like Cleveland Clinic. But nonetheless, is it complicated? Like, is it a hard, tedious process to actually get somebody to bring you on?
Yeah, there's a lot of factors in
the way you want them to pay you.
Right. Let's start with the the baseline that the physician does not have any complaints or lawsuits, and like the background is everything's good. Let's start there as a baseline.
So you're solid. You're a solid physician.
Yeah, you're a solid physician. You're people trust you as a physician. You would do a solid job, and now you're looking for a new opportunity. Then it starts to depend on your specialty. So me as a family physician, there is a national primary care shortage in the U.S. pretty much in every state.
Really?
So, yeah. So for me, and that's why, if you kind of read up on it, that's why they're trying to increase the independence of nurse practitioners to kind of help out with this primary care shortage. Because, there are some places where, in order to see a family physician, you got to wait months, which is just, we live in the United States. That should not be something that's going on. So there are ways that they're trying to kind of resolve and mitigate this issue. Mm-hmm. But overall speaking, yeah, because there's such a primary care shortage, that makes it a little bit easier for us to find a job, because we're just needed so much. You have these areas where it's just hundreds and thousands of patients just waiting for a new physician to come. So these hospitals and these clinics are like, please come this way.
What's the difference? Because I guess that's what's kind of throwing me off. And I know there's so many different doctors. You have so many different specialists, obviously. Yeah. But what is the family physician doing differently than the doctor who's, I don't know if they are, I apologize for all the terminology concerns, a little confusion right here, but the doctor that's in that major hospital.
Yeah.
And they're working and they all have different jobs inside that facility. What's the major difference between somebody who actually specializes in family treatment?
Yeah, because there's so let's back up and say, like, what does every individual on this planet need? Every individual on this planet does need, well, let's just stick with the US, needs a primary care physician, and why is that?
And that's what you are, because that's
right. That's what I am, right? So, essentially, I look at family physicians like myself as the front line of both offense and defense. Let's say you come into my office right now, you're healthy, you don't really have, let's say nothing's wrong with you, and I come in with the complaints. but we need to keep you healthy. We have to make sure nothing's hidden in your blood work. I gotta, do my full physical exam on you. And I gotta make sure that, there's nothing you want to talk about in terms of your health. So you're completely healthy. You need to be seen, right? That is our job. At least on a 1-year basis, we're going to be doing a comprehensive wellness exam on you, right? And then also, depending on your age, how you get that comprehensive wellness exam, it changes. You're gonna need a colonoscopy. You might need prostate cancer screening. If you're a female, you might need your Pap smears, your your mammograms, right? We got to make sure you're not smoking, drinking, and if you are, how much you're doing. You may not, you may now have high blood pressure, and we're just finding it, or your heart rate's elevated for some reason, or you've been sad and tired, and you never knew that your thyroid was out of whack, and we checked that through our blood work, right? So there's so many things that family physicians could do for just a healthy patient, right? So, and that's why every single patient, every single person, really needs a family physician. So because of that necessity, it's just tough to have that many family physicians to cover each patient. Then you deviate towards, okay, so why aren't there any shortages of, cardiologists and nephrologists? Well, because not everyone has a heart problem, cardiology. Well, not everyone has a kidney issue, nephrology, or, oncology. Not everyone has cancer, an oncologist, right? So there's not as much national need for those specialists, right? So that's kind of like, that's really the short. It's kind of just like the how you break down the volume of patients and where they would go for follow up. So everyone needs some sort of primary care physician, family physician to keep an eye on them. And then if I find out you've been having chest pain when you walk the block, okay, now I'm going to take you to now I'm going to refer you to a cardiologist, and you're going to see them, right? So it's just really the kind of break down the math of it all.
Based off of specialists and knowing that, it took me a while, and even now I'm starting to feel a type of way about my family physician, my primary care, and it's not his skill set. It's the fact that he essentially has residents checking on me now. And it's like, I don't have a consistent person, and that's agitating me. So that's where the disappointment is coming in, because it took a long time to find somebody that seemed like they actually cared.
Yeah.
What exactly is it that you do? Because I know if, like you said, if there's something on my heart, if I have an extreme rash or something like that, my eczema breaks out, you could easily be like, yeah, we need to send you to a dermatologist, send you to the cardiologist. So knowing that when those major issues come about, you're going to refer me to someone else, what exactly is it that you do? Perfect example, because this was a frustration of my own. I had years ago a cyst.
Okay.
And where it is, apparently it was on the artery or something like that. Not artery. Is that right? The main vein.
Maybe it's on a vein, or
I could have died if they did it wrong.
So probably artery.
Yeah. Okay. I just want to make sure it was artery. Okay. Yeah. So nonetheless, I remember going in there and it was a ganglion cyst, and it was like, I looked it up. It looks like I have a ganglion cyst. From what I was told, it's most likely a ganglion cyst. I had to sit there for an hour waiting for them to come back in. The woman was like, I don't know what it is. It's okay. Just wait till the doctor comes in. He comes in and says, you have ganglion cyst. All right. Yeah, we're going to send you somebody else now. I had to come to you for you to point at something and tell me what I told you before I came in, and had to wait almost an hour. And then you left. Like, it was like he came in, yeah, that's a ganglion cyst. Okay, we'll get you set up for your surgery and everything. All right, see you.
Yeah, I got you. I hear you.
Yeah, so please elaborate a little bit for people who want to understand the primary care physician, what they're actually doing, and what are you covering?
Yeah, so the general kind of like responsibilities of a family physician, is the comprehensive care of patients, right? Whether that's an acute or chronic condition, in collaboration with their specialists. So it's hard to go over every single thing that we do, I'm gonna be on here forever doing all of it.
Yeah, don't do that. Let's
Yeah.
nice.
But let's kind of talk about. I'll just kind of run through some of the more common things. I'm just trying to, I'll just think about like a day of patients that I have. You can have a day where, like I said, some folks of any age is coming in for that general wellness exam. They just want to make sure that their vaccines are up to date. If they're not, we give them to in our office. That they have their yearly blood work. So we're checking all those things, making sure the vital signs are good, making sure they have their maintenance screening, their colonoscopies, pap smears, all those things I talked about, that they're up to date on all their current medications. They might be on 5 or 6 of them. I got to make sure they're taking them the appropriate way. You take it at morning with water, at night before you go to bed, right? Got to make sure all that stuff is squared away. So that's just the wellness exam comprehensive portion of things. And then you start to go into what are some patients who they come in for acute issues, right? There's something happened 1, 2, 3 days ago, boom, and they want to see their family physician to address it. So what are those things? You can have, headaches, migraines, upper respiratory infections, UTIs. Some folks have chest pain, pneumonia.
You can treat all these things,
right? Yeah. So I was gonna say the treatment of all these things. Whether it's acute, chronic, it depends on the family physician's prior training, current maintenance of that knowledge, right? And then their comfort level. So let's say you come in with a bunch of weight gain, fatigue, you're just feeling colder than usual. And then you tell me my mama got thyroid issues. Okay. All right. That's going to make me think, all right, let me do some blood work on you. And I notice that your thyroid is messed up. I can send you to an endocrinologist, the thyroid experts, and I can have them do the medications and all that. But really, as a family physician, if you had, some sort of, some relatively decent training, you can treat that yourself. And I do that a lot. So the example you gave with the ganglion cyst, there are family physicians who can treat that in their office, right? They've done enough ganglion cyst procedures. They've done enough training. They see it enough where they say, hey, I feel comfortable doing it. Boom, let's do it today, or follow up and meet with me in a week or later, and I can do it then. Others say, I just don't see it enough. I'm not, it's next to an artery, or it may be next to a major vessel. I have not done it enough. I may not have the right equipment in my office. I don't have the lidocaine to numb that area. I don't have the syringes, the needles, and everything, right? I don't have the medical staff to help me out. So it's better if I send you to, the dermatologist or ortho doc or whatever the case may be. So there's different reasons on, why some family physicians may do this, may not do that. But overall, we have our, we treat our acute conditions, some of the examples I talked about. And then a lot of our focus is on chronic conditions as well. Anxiety, depression, COPD, diabetes, high blood pressure, high cholesterol. We see all these things every single day. And a lot of it, we just treat ourselves. But a lot of it, we need help. We got to send them to a dietitian, a cardiologist. If the kidney functions start to look crazy, and it's like, hey, you one step away from dialysis. We don't know how to do dialysis. So you have to go to a nephrologist. But essentially, so that's what I meant in the beginning. We are the front line of offense and defense. We're just constantly keeping an eye on everything. Our goal is prevention. We want to stop you from getting that heart attack. We want to stop you from getting that stroke. We want to stop you from, losing your leg to diabetes. Right. That's our main goal. But there comes a point where, this is now out of my expertise. Boom. Then you refer that over. But like I said, the out of my expertise is relative. It really depends on prior training, holding on to that training, and kind of maintaining that moving forward.
Okay. So I have 2 questions.
Yeah.
It sounds a little bit funny. So answer the following question at the same time. So
okay.
First question, and it's more of a state. I guess it's more of a statement. I've heard the quote of the best doctors don't have a lot of patients in their waiting room. And with that being said, are you paid? Matter of fact, how are you paid? Are you paid based off of patients coming in? You mentioned that you actually are there for a set amount of hours compared to the doctor who is on call and is at the actual clinic or whatnot. How is your salary paid out? Like how do you get paid? And then let's talk about money throughout your whole 12 years of the process. We at the point where we need to talk numbers so people know what they're getting themselves into.
Yeah. So what was the first quote you said? The
best doctors have no patients in the lobby because they're all healthy.
I like that.
I mean, you mentioned already, I'm trying to help prevent you from getting heart disease. You're coming in for your physical therapy. You're not your physical therapy. You're coming in for your physical every year, maybe once, twice a year. And we're checking on you, finding out what's going on with your blood pressure. And we're getting those things addressed. And because we address that, you don't have to come throughout the year because you're one of those people who are safe and not breaking legs and toes and fingers all the time. So
yeah, the quote sounds really sexy. It sounds good, but I think it does physicians a disservice. Like now you're always going to have patients, whether they're healthy or not healthy, they're going to be in that waiting room. Because like we said, there are a lot of healthy patients who come in just to stay healthy, right? Mm-hmm. And then you have a lot of patients who, because of genetics, kind of lack of proper kind of health literacy or cultural things, right? I live in Louisiana, so folks gonna eat their crawfish, so that's why it's just filled with salt. So you got blood pressure, right? So you have so many different factors that lead people to having certain medical conditions, and for the most part, it's just not their fault. They just don't have the right resources, education, and guidance to actually empower themselves to stay healthy. So now I would say this though, for your quote, if they are in the patient room waiting an hour, 2 hours to see the doctor, okay, then we got a problem. You got to kind of make, physicians are all about like time efficiency. So you don't want your patients just waiting forever to see you. That definitely is a frustration I agree with.
So how are you paid?
Huh?
How are you compensated?
Yeah. So look, every physician's different, right? It's all what's in that contract. Everything's negotiable. But for me, and I think I can speak for a majority of other physicians, is when you have your contract, your first year or two, whatever the case may be, you can have a guaranteed income. Meaning
salary,
right? Guaranteed salary. You see 0 patients, you see 1,000 patients, you're gonna make the same amount. Mm-hmm. And then after a certain agreed upon years, then you start to, then it starts to be based off of something called RVUs, or WRVUs, work relative value units. And even me, I'm not even like an expert on this, but essentially, like every kind of billing code you put in, every visit you have, every procedure you do, everything has a particular RVU to it. And you essentially, based on your contract, you have to meet a certain amount to kind of hit that agreed upon salary. If you don't reach that, you might have to pay some back. If you go above it, you'll get a little bit extra. All right. So that, that's kind of, at least for, for my job, that's kind of how things go. So, essentially, if you see more patients, if you deal with sicker patients, if you do more procedures, you typically get paid more in the most simplest sense. Mm-hmm. So, if you're a physician that only sees 10 patients and that physician sees 30 patients a day, they'll probably end up getting paid more. If you are a physician who is more procedure heavy, surgeons, right, things like that, they typically get paid more, which correlates well with you can Google and see the salary difference between a family physician and a orthopedic surgeon, right? They do more procedures, so they get paid more. So that's typically how salaries go. Yeah.
Okay. Well, let's talk this money, man. All right. Yeah, so engineers, they tend to get paid during co-ops. I know construction co-ops, they get paid as well. At any point during your education, well, better yet, at what point during your education did you begin to get paid? Was this once you enter medical school? Obviously, I would assume you're not getting paid in undergrad like a person that's in engineering. But in medical school, is that when you started getting paid? Talk about that. And let's talk about what the number was. That's important. I need to know what that price tag was for your work.
Yeah. So, yeah, like you said, college, I'm not getting paid. Med school, you're also not getting paid. You're actually paying them to get an education, so, and that can range from after room and board and all that, maybe every year in med school is about 60 to 80,000 that you're kind of taking out loans, right? Because not everyone has, family members that can help pay for med school. It's a lot of money. So typically you're taking out loans. So keep that in mind before I talk about salary, that, if you guys want to come into this medical field and you don't have the, the financial, comfort to pay for med school, which a majority of students don't, you're going to be taking loans out, which is completely okay. That's what students do. So yeah, you start getting paid in residency. So after the 4 years of med school, you graduate, and then you're in your residency training. The one I said that was about 3 to 7 years, depending on your specialty. That's when you start getting paid. That is not even near how much you would get paid after you graduate. So at my program, and it changed. So mine was a 3-year program, and you increase the amount you get paid every year. I think I started at maybe 48,000 every year. I think it was about 48,000.
48. Okay.
Yeah, and you go up a couple.
Might told me about 60. I was talking to a financial advisor, and he said some of the doctors he's worked with.
Right. So it depends on the location you're at. So my buddy, he graduated. We went to the same med school, and he was in New Jersey and New York, because cost of living is a little bit higher there. He started off getting paid high 50s, low 60s. And in Cali, you can get paid a little bit more. Louisiana, down here, you get paid a little bit less. Cost of living is a little bit less. So I got like 48, then I think it went up to 51. And then because I was chief resident in my last year, I got paid a little bit extra on top of the already increased salary. I think it was like 53 to 54,000.
What age were you when you were making 48?
How old did I go in? 27. Yeah, I was like 26 or 27 years old. I'm 30 now, so yeah, 26 or 27.
That's interesting. So for clarity, everybody, like when I came out of school, remind y'all, I talk about it all the time, I was getting paid 30. I did some real work to finally earn my salary that was strong, a good 35. Oh, yeah, that was about 4 years. And then I would say it was probably about 27 is when I was blessed. I can't say anything less than that. It was a blessing. A position came open and I was making 47. And that's when you feel like you're doing something. So even though he's talking how many years in school, I just want to be clear, 48,000, and he's getting an education at the same time is a pretty good salary, especially if you talk to people around you. 48,000 at 27, honestly, you could be making less depending on where you're at. So don't get intimidated by the amount of years, because that's what I want to point out was like he is starting to get paid. And frankly, when it comes to that grad school, I keep calling it grad school, med school, during those years, you mentioned 60,000 a year, which holy crap, we're talking about 240 as student loans. I did that math. We're talking about 240. We're not even talking about undergrad if there's no scholarships involved in there. Right. But I'm assuming that the amount you're getting paid as soon as you graduate, because you said once you get out of that residency, outside of that 48, 60 plus thousand, that sky is a different limit. So let's talk about that part. Now you out of residency, so you have 48 the whole time?
It was residency was about 48, and then like 51, and then around 53 to 54 in my last year of residency. And
is that just based off of the fact you were there, or was it the fact that you're getting better? I'm trying to figure out
the fact that I was there. The fact that you were there, you're always going to get paid. Yep, you always typically go up as long as you stay within that program. Yep, you're always going to go up. Yeah, that's kind of standard for all residency programs. And then once you graduate, then your salary goes up, substantially. All right. So kind of average for me as a family physician, average starting off, you're going to range, and this also depends on where you're at. But just generally speaking, the average is probably 180 to 220. That's probably the average, 180K to 220,000.
That's starting salary.
Starting salary, right. But hey, look, if you end up moving to an area where it's just super saturated with family physicians, you might be on the 180 side. But then in that same breath, if you want to go, there are folks who go to just the most rural area in Utah, Idaho, and they are just in dire need of a family physician. You can get paid 250, 300,000. Like, this stuff happens. Like, that happens. Obviously it may not be, you're where the quality of life you want, or, what you planned on, but just know that the salary, just the opportunities are they're vast, just kind of depending on, your geography, like I mentioned. But typically the average 180 to 220, that's typically the average starting off.
And just for people to understand, I did some quick math. That's over $10,000 a month. Yeah. So I know you heard that debt that he talked about, but if you have a good financial advisor, even in his position, and you're handling money well, it sounds like you get out of debt in a reasonable amount of time with proper decision making, or you could stay in it if you want to. I don't know the lifestyles of doctors, but I just want to make sure people do this correctly, because the 9 and 10 years, the 12 years can be extremely intimidating, and be like, I don't want to do that. But I don't know many professions that and there are a lot, which is why we got anything out here, so we can expose people. But nonetheless, this is a position where, wow, that's really impressive. In fact, it sounds like you're making all the money back that you would have been earning during those years prior to 27.
Yeah, this job, outside of the joy we get from it, from taking care of the patients we want, the financial security is there. It really is. Like we said, it's a lot of years. You're going to be, in debt, relatively speaking, to a lot of our counterparts in the, other professions. But because of the amounts you make, and if you are smart with your money, you live with some sort of frugality, and then you invest appropriately, those loans don't mean nothing, man. They really don't, because another thing you got to understand is, when you're paying back loans, it's not like they're asking, hey, I want $5,000 a month. No, there are so many different types of repayment programs where I'm literally just paying a couple $100 a month, and it doesn't change anything about my life, about buying a house, buying a car, having children, like vacationing here and there, seeing family, having a nice Christmas and getting some, some decent gifts. Doesn't change any of that. Right. So, but I think a lot of people don't understand that. All they just see is, lump sum of debt. I can't do nothing. I just got to pay that back the whole time. No. And plus, even when you negotiate contracts, there's so many programs that say, look, join us and we will pay back your debt. We'll help pay. So the program I'm in now, that I'm going to be starting soon, hopefully they offer $40,000 a year of loan repayment for the next 4 years. And that's not like an unprecedented thing. Like, this is just what programs do. They want to do that. So the point being, like you said, the loan should not be something that scares you. If you're really passionate about this, you move forward, you become successful, you're going to have a nice salary. And there's just so many just wonderful options to pay back your loans or help get your loans paid for you. It's golden. It really is.
So I'm just curious, did they give you all like a party at the end of the year when you finally finished residency that said, hey, congratulations, you won? That's
kind of what it felt like. That's kind of what it felt like, man. We were like, man, we actually, because, for you in your class of like 200 people, everyone's, for 4 years, you just look at the same goal. So, we're getting our diplomas. We're just like, man, we did it, man. This is crazy. We actually really did it, man. And some of them we still keep up. Some are in Minnesota, Florida, Philly, they're DC, a lot in different areas. We're just like, every couple of months, we just keep up with each other, and everyone's just climbing the ranks, man. It's good. It's beautiful.
I'm assuming doctors can make up to $1 million, because if you're doing that, the 180 to 2 something, that's you talking about probably within like prior to 40 years old, it sounds like. So what are we looking at that doctor that's been in the industry for 20 plus years?
Yeah, I think depending on how long you've been in, like you said, and then the type of physician you are, I I wouldn't be surprised if you can get up to the the million range. I would say.
I mean, obviously a primary care.
Ooh, I wouldn't hold your breath on that one. If you find one, let me talk to him. let me talk to him and pick his or her brain.
I mean, I think LeBron's family physician probably is getting paid around that, if I had to guess.
Yeah. But I think typically the high six digits, the $500,000 and above, I think those are more of your surgical specialties.
Okay.
Yeah, your orthopedic surgeons, your plastic surgeons. Now, there are probably non-surgical physicians who can reach that salary depending on geography, depending on little side hustles and other, kind of passive incomes or whatever the case, or other, kind of dual jobs that they have. But based on how the payment system is right now, it typically is those surgical specialties. But if you just back up and,
what's yours?
What's that?
What's the apex? What's the apex for the primary from at least from what you heard?
I think about 350, 400, and those are in those rural areas. Those are mostly in those rural areas. Yeah. But man, really,
the rural areas.
Yeah, as a primary care physician, the rural areas are typically where you make more money, just
because you're the guy, you're the gal in that area. Okay,
yeah,
that makes sense. That makes sense. The big city, there's a whole bunch of you there, and they can spread. Okay, I was actually thinking that you were going to potentially make a whole lot of money if you were to go to New York or Cali, but that might all get going into wash based off of how much the city is taxes and all that stuff, and then all the people out there. Okay, that's good to know. So you want to go to a small town and grab that bag. I see you going down to Texas, you getting into the big city, and then you going, hey, what's going on down the street?
right.
Just wait it out. Okay. Yeah. Well, we're reaching the tail end, but I haven't done this, which is making me excited. I might actually do some rapid questions in the future because, and I don't know how rapid you can make them, but if you can make them as concise as possible and allow people to understand, hey, there's more information here, let's do that. First question, what were you getting paid? Not where were you get paid. What were you learning? You said when you were in school, you didn't really start focusing when you were in med school. You didn't still start focusing really on your actual focus as a primary care physician until that last year. Mm-hmm. So what were you learning prior to that? Once again, just make it quick.
Like in college, you're talking about the college years.
No, when you said when you went to med school, it was that last year of med school was when you really locked in on family treatment.
Opposed to gotcha. Yeah.
So other years, what are the surgeon, the cardiologist, all of you all are in the same class at that point prior to picking. What are you all learning at that point?
Well, first 2 years of med school, all the students, no matter what you want to go into, you are all in the classroom, lecture on the screen, and you're learning all the same thing. So it also depends on the med school you go into, but for our at Ohio State, our classes were breaking into organ systems. So, for example, for a month or so, you're learning the cardiopulmonary system. So it's nothing but heart and lungs. You take your big test, pass that, and then you move on to the next thing. Next thing is MSK, the musculoskeletal system. So you learn about anatomy, physiology of muscles, tendons, ligaments. Take your test, boom, move on to the next one. Next one is neurology. You just everything about the brain, cranial nerves. I mean, you're in the anatomy lab and you're quite literally looking at an actual, brain on a cadaver. Move on to the next thing. So you just kind of go through every organ system for those first 2 years.
Okay.
And then the last 2 years is when, boom, you start hitting those hospitals. You start hitting the clinics. You start shadowing. You start working with the doctors, the residents, right? You're working with all them. You're now using those 2 years of education and you're putting it into action, right? And in those last 2 years, you see, because you're rotating in these different specialties, then you're like, which one do I want to do? I already knew, it just confirmed it for me, but some folks don't know. So those last 2 years, they're like, you know what? I really liked my psychiatry rotation. I think I want to be a psychiatrist, or I really like my OBGYN. I love delivering babies, taking care of women. I think that's what I'm applying for. So that's kind of how med school is broken down.
Okay. Since you mentioned the fact that you were surrounded by, towards the tail end, you were shadowing people.
Yeah.
I was already in there. It was perfect. Mentors, how many of them did you have? And their significance.
I see a good probably two or three solid mentors.
And what does a mentor look like for a med student? What does that look like? And even I'm assuming you probably have connections and probably mentors now. So what is a mentor look like?
Typically, one is someone in the specialty you want to go into, right? That's one. And then another one would just be somebody who is there for the emotional support and kind of helping you through the trajectory of getting to your specialty. And again, it doesn't even have to be somebody who's in your specialty. It's kind of all the other little small intricacies of applying for a residency program. So the two that off the top of my head, it was a family physician who helped me through when I was in charge of the interest group, who helped me set up shadowing, who wrote one of my letter of recommendations. Right. So that was one of my mentors. And then the second one was the associate dean of admissions at my school. Another Black male in medicine, which is quite rare, if you look at the statistics, right now in this country. And he kind of helped me get into the post-bac program. He held a lot of seminars and meetings with other Black males to kind of make sure we knew, hey, we're all doing this together. We're all doing this together. So he was part of that emotional support to kind of help me, actually graduate med school and get into residency. So mentor doesn't have to look like you. Sometimes it helps if it does, especially for, minorities in medicine. But typically
they've had your own struggle and they know what you're going through.
Right. They understand. Yeah, they understand that. But typically someone within your specialty. And then, like I said, someone who is there for that kind of additional support it takes to get to where you need to be.
Yeah. Ohio State. You stayed at Ohio State the whole time. Some schools, when it comes to graduating and getting your education, you want to go and get it at another location. Was there something special about Ohio State, or does the medical degree not require you to essentially have a diverse education base? You know what I mean? I know some people, they could go to Harvard for this and then decide to go to Yale for this in after school. So is that not a thing in the medical, or was it just something special about Ohio State that it didn't matter?
I'll say for me, it was a little special, a little unique. So remember I did my 4 years of college, and then that 1 year post-bac program I did, remember it was Ohio State, and that one was a linked post-bac program to the medical school. So as long as you fulfill all the requirements for that post-bac, you matriculate and can only matriculate into Ohio State Medical School. I could have still reapplied and gotten somewhere else, but the guarantee and promise that came with Ohio State Medical School, that's essentially, the uniqueness of this post-bac program. So so for example, when I applied for post-bac, obviously I got into Ohio State's post-bac, but there were some in New Jersey, there were some in Texas. Those were unlinked, so I would do the 1 year. I would have done the 1 year at those programs. I would have done the same thing, take those rigorous classes, retake some college classes, retake the MCAT, but I would have had to reapply to medical school, re-interview, and cross my fingers and hope I got in. So I didn't have to do that through this Ohio State post-bac program. I just had to fulfill the requirements. And if I met those requirements, I would essentially automatically matriculate into Ohio State Med School without having to reapply, re-interview, do the whole rigmarole. So that was the uniqueness of the program I was in. But, if you're not in that unique situations, there's nothing wrong with, doing college here, med school here, residency here. There's nothing wrong with that. Some folks tend to stay in the area they're at because they have certain connections. They understand the certain prestige or the actual resources available for your education. So some people say, look, and Ohio State was one of those places too, man. Ohio State, they are, when it comes to being at the forefront of medicine research, Ohio State is just one of those top-notch universities and medical programs that offer that. So, So big ups to Ohio State, but yeah, you don't necessarily have to stay in that general vicinity.
Okay. Mm-hmm. And I heard Damon John talk about this. I know this might go too deep, so just try to be concise with this one. He mentioned once he finally got paid with his health issues, and this is how he caught his cancer early, when somebody came to him and said, hey, man, you're getting paid well. We need to go ahead and get you the executive physical. What is that? I mean, he gave us some of the ideas of it, and I was just like, he was like, yeah, we're getting paid so you can afford the executive physical where you get the whole, well, I'm giving some idea what he said. He said from head to toe, they're checking everything. We're learning everything going on in your body, and we're going to make sure that you are completely ready to go out there at full capacity. That's at least what I took in as what an executive physical is. Have you heard of this? Because it seems like I'm seeing your face. Like, yeah, this ain't anything that they've talked about with me. What is that about?
Yeah, it's not an actual thing. It's not like you're gonna find it in a textbook or it's gonna be taught to you by your supervisors or your upper levels or whatever the case is. But I guess I can speculate that when they say executive physical, I'm assuming that they just, when it came to like blood work and kind of checking everything, they just threw the kitchen sink out there, right? Mm-hmm. They just said, literally check everything from A to Z and see what sticks to the wall. You can't do that in the real life with every single patient you have.
Of course.
The healthcare system, like we're already in debt so much right now, but we'd be crazy that the healthcare industry would just be in terrible shape if you were to do that for every single patient. But
I said executive. Right, that's why it's like executives. Yeah.
I guess for him, because he had the financial, comfort to do that, he's able to, hey, I'll pay out of pocket for any little extra thing. Check that. Boom. Let me do all that. Obviously, not all patients have that opportunity to do that. They have to be. This has to be based on what their insurance will cover and things like that. So yeah, insurance does not cover kitchen sink medicine.
All right,
it don't cover that.
Well, you just led me to the final question, which I told you about in advance.
Yeah.
Why can't we just see the prices when we come in? Like when we go into McDonald's and see that the number one is $5 and the number 2 is $7. Why is it such just this ambiguous number that we find out later after we got the actual care, how much the X-ray, the MRI, or CAT scan, like what's up with that? What's the story on the price tags, and where can we find it if we can?
Yeah, it's a big frustration for both patients and doctors, because it's like, let's say you come to me, hey doc, I've been coughing for 2.5 weeks, it's getting worse. I got green phlegm coming up. Okay, well, I'm gonna order a chest X-ray, right? I'm gonna get a chest X-ray, boom. But when we order that, I as a doctor, I have no idea how much you're gonna have to pay for it. I don't know your copay, I don't know your deductible. I don't know if they're going to send you a bill 6 weeks later. Hey, this how much insurance paid and this how much you got to cover. I don't know any of that. I think some patients think we do know that, and we just like trying to get money from. Yeah, we don't. I'm telling you, you can look at our screen when we order it. There's not a number next to it like McDonald's $5 meal. There's nothing there. Jeez. So that's generally the standard issue, and I think the biggest reason is because one, there's so many different insurance companies, and every patient has a different plan within their insurance company, different premiums, different deductibles, different co-pays. So because of that, there cannot just be this lump sum number if you're going through insurance and you're dealing with that. Mm-hmm. Now, there are physicians who are trying to resolve and answer this issue. So there's something called direct primary care, which is they're eliminating that middleman, the insurance, and they're kind of creating that kind of fast food menu where they do have a number to it, right? So, for example, one of my buddies, who I'm in this mentoring program with, he just opened up his own direct primary care clinic down here. His name is Dr. Byron Jasper. It's the first Louisiana Black-owned direct primary care, and he's trying to address
Brian Jasper. Let's make sure we know that.
Dr. Byron Jasper. Yeah. Shout out to Dr. BJ. But he is, he opened up his own direct primary care clinic where, patients come in they, they pay a particular amount to the physician. It could be on a monthly basis. It could be on the annual basis. They get to spend way more time with the physician, up to an hour, as opposed to the 10, 15 minutes you get. Right. And then if there needs to be a medication that he needs to give to the patient, if there needs to be a certain imaging test, if there needs to be a certain lab work, they can ask him, hey, doc, how much that costs?
Yep.
He got the sheet. If you wanted to pick up this medication, it's $4. If you wanted to get that chest x-ray, it's $50. Now, this is not a standard thing,
Is the insurance involved in this? Like, can I still get my insurance involved and have them?
You can still have insurance and be part of this direct primary care. Okay. I don't know the answer. You probably can still run your insurance through it. I don't know how that would change pricing. But
that's why I asked, because I'm like, it sounds like this is probably a more expensive route if you don't have your insurance involved. So I figured at least let me know the real number, and then I can reach out to the insurance. And they can give me that lower number.
Yeah, no, but essentially, the biggest benefit of direct primary care is you have that. That number without any, skepticism, any deception. The number you're going to be paying before you get that blood work, before you get that imaging test, before you get that medication. Boom, you already know it automatically. And it's typically, cheaper than standard healthcare. That's really the whole purpose of things like DPC, which is direct primary care. So we're trying to find answers to it. It's not it's not everywhere yet, but it's definitely something that's kind of building up in this country.
Okay, well, man, I tried, y'all. I got the answer. Whether it was the answer you wanted, this the answer we got, and I'm so happy that my guy gave us some time. With that, let's finish out this with your final thoughts. If you feel like there's something that someone needs to know that you didn't say that can accelerate their success in this industry, what may have helped you? Is there a book that you read that's actually allowing you to elevate yourself? Give me your final thoughts.
Yeah, we touched a little bit about mentorship, right? We touched on that, and I think let me expand on that a little bit. Mentorship in whatever context is extremely important, especially for individuals trying to get into medicine, and then especially for minorities trying to get into medicine. So right now, in the whole U.S. physician workforce, Black folks really make up about 5% of the physician workforce. And then of that 5%, Black men make up less than half of that. There's actually a statistic right now that the Black men that tried to that applied and matriculated into med school back in the 1970s compared to 2016, 2017, there was actually more back in the 1970s, right? So we're doing better in a lot of different areas: business, law, entertainment, athleticism. But in medicine, we ain't doing so hot. So we got to find ways to address that, So, mentorship is that first, one of the biggest, stages to get to that success and actually increase those numbers. So I'm actually vice president of CMMP, which is Comprehensive Medical Mentoring Program, which that's our biggest goal, to help guide, nurture, and get minorities into medicine. So look us up, cmmpmed.org, look us up online and follow us. We have social media platforms. And we can help you get to where you need to be. If you truly want to be a doctor, we can help get you there. And to another point, you and I talked a lot about the trajectory of this journey, the loans, the number of years, and that the work ethic and dedication that comes to get there. I think we all have it. Every single person who has that idea that they want to be a doctor, they can get to where I'm at right now. It just takes having the right information, the right attitude, and the right people in your corner to get there. We all have that. So I hope you all, see the interview we had in full. I hope you do kind of keep an eye and follow up with me through whatever resource you find me, so we can help you get there. And if there's anything I didn't answer, I can give you some more answer to that. But Black success is something that, I'm constantly proud of. I'm always excited about. And, if we can help get you there through any means, please get in contact with me, and I'll help the best I can. But I appreciate you for having me on, man. I appreciate it.
Do me a favor, repeat that organization one more time, and if there's a website so they can go ahead and get that.
Yeah, the organization is Comprehensive Medical Mentoring Program, CMMP. The website is cmmpmed.org. and we'd be excited to have you on, and we're looking forward to it. Looking forward to it.
I appreciate that. My thoughts, man, what I took away from this was do the hard thing first. Like, you never said that directly, but when you're going to school for that long, if you're doing that hard thing first, the outcome clearly pays off in ways that many people don't get to see because they didn't decide to do the hard thing first. He's a doctor. So if you don't do the hard thing first, when he tells you to do it, you might have to deal with a whole different level of hard things coming down the pipeline. So do the hard thing first and be able to receive the rewards of laying that foundation that's going to reap the benefits of a beautiful mansion that you're putting it on. So I appreciate this time. I got so many more questions, so many different things I would love to bring up. Oh, by the way, if you want to be even more impressed about him and his family, this guy and his wife are both physicians, just for clarity. Yeah. And they're helping the statistic that he was talking about when it comes to the percentages of minorities and Black specifically in this industry. She's an OBGYN, correct?
Not correct. Yep.
Yeah. So just wanted to give that shout out to make sure that you all knew that household is putting in that work and making differences in lives and saving lives. So like that, I appreciate your time, man. 2 of these.
Absolutely. Take care, brother.
Whoo. All right.